بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله الطيبين الطاهرين وأصحابه المختارين. السلام عليكم ورحمة الله وبركاته. Now we are going to talk about the management of severe preeclampsia. We will talk about the management of preeclampsia in general and specifically about the severe preeclampsia. So as we know in medicine, the prevention is the first thing to be done in the process of management of any disease. The question which we should ask ourselves is there is any preventive measure or strategy can be done to reduce the incidence of preeclampsia. Many studies have been done on many elements and in many supplements, and have been proving that calcium supplement can be effective in patients who have low baseline calcium intake. The other things, low dose aspirin, and specifically in high risk patients to be exposed to the preeclampsia, and have been found to be associated with lower the incidence of preterm preeclampsia. The second most important step in management is early detection. So, is there any screening method to identify women at risk for development of preeclampsia? Different modalities have been done to screen a patient for early detection of preeclampsia. Good history taking forms the base of the early detection. So by good history, you are going to distribute your patient into high-risk group and low-risk group. In low-risk group, the by doing different screening modalities show a very low positive predictive value ranging between 8 and 33. In other words, there is no good screening modality for a patient in low-risk group. Where in high-risk group, in the first trimester of pregnancy, uterine artery Doppler study alone have a low predictive value for the development of early onset preeclampsia and even lower value for the late onset preeclampsia. But when you combine low maternal serum concentration of placental growth factor, in addition to the Doppler study of high uterine artery pulsatile index, will identify 93% of the patients who would develop the preeclampsia, and specifically who will require delivery before 34 weeks of gestation. We talk about early detection, we talk about the prevention, and now we are going to talk about the management of cases of preeclampsia. The definite treatment of preeclampsia is the delivery to prevent the complication which could occur from the preeclamptic disease progression. Delivery versus expectant management. Very attractive title. So when we think about the extreme prematurity, where we are going to have a long trip, very early preeclampsia, does it work to do expectant management for these patients? When to do expectant management for preterm? In other words, when to deliver patients with preeclampsia? Is all the patients of preeclampsia should be delivered immediately? All this question will be answered. Patients with preterm fetus, if she has gestational hypertension or preeclampsia without severe feature, put a line under without severe feature. Continue monitoring until 37 weeks of gestation in absence of abnormal antepartum testing, preterm labor, preterm premature rupture of membrane. So we can conserve the patients with mild preeclampsia, no severe feature, up to 37 weeks of gestation. How to follow up this patient? Serial ultrasound to determine fetal growth, weekly antepartum testing. So here we are covering the fetal side. What about the maternal side? Close monitoring of blood pressure, weekly laboratory testing for preeclampsia. So whenever you decide to do expectant management for patients with mild gestational hypertensive disease, you have to monitor the fetus and the mother. What about the patient with a severe feature of preeclampsia? Expectant management of early preeclampsia with a severe feature prolong the pregnancy for 1 to 2 weeks, has low maternal risk, and improve the neonatal outcome. Maternal evaluation for either the development or worsening of the preeclampsia, and laboratory follow-up with weekly evaluation of platelets count, serum creatinine, liver enzyme, and kidney function test is recommended. In this situation, in this particular group of patients, we are not doing expectant management unless they are fitting for certain condition. So what is the condition precluding expectant management? Now we'll talk about what is the condition precluding expectant management. Before we talk about this condition, we have to know that the patient who is far away beyond the viability, or patients more than 34-week gestation who have severe preeclamptic feature, these patients, they have to be delivered. But when we are talking about these conditions who's precluding the expectant management, in between 34-week and the viability. So any patient above 24-week till 34-week or 33-week plus 6 days, those the type of patients who we are doing expectant management. So this condition, as we think, always I said, think in 2 arms. The maternal condition and fetal condition precluding expectant management. So maternal condition precluding expectant management. Number 1, persistent headache refractory to treatment. Development of visual symptom, motor deficits or altered sensorium and stroke. Development of eclampsia. Development of myocardial infarction or pulmonary edema. Persistent systolic blood pressure more than 160 systolic over and more than 110 or equal to 110 diastolic, which is not responding to antihypertensive medication. Epigastric pain, right upper quadrant pain, response to repeated analgesia. Aminotransferase increase and reach level more than 2 than the normal. HELP syndrome or progressive decrease in platelets count less than 100,000 per microliter. Coagulopathy in absence of alternative explanation. New or worsening of the renal dysfunction, serum creatinine greater than 1.1 mg per deciliter or twice the baseline. Suspected acute placental abruption or vaginal bleeding in absence of placenta previa. Preterm labor or preterm rupture of membrane. Remember, some of these signs and symptoms, they are a sign of symptom of severe PET. So what we are going to do, if there is deterioration in some of these, like liver function test, kidney function test, if there is deterioration of it, then we will consider to terminate the pregnancy. Some of these symptoms, it's a red cut line. You cannot ignore it. You cannot do conservative management in eclampsia. You cannot do conservative management in patient's situation, life-threatening situation for the patients. Fetal causes or condition precluding expectant management, like fetal death, or fetuses who is having without expectations for survival with multiple congenital anomaly or extreme from viability. Non-reassuring fetal testing like persistence reverse in diastolical flow in the umbilical artery
or estimated fetal weight less than 5th centile, severe oligohydramnios. In some of these cases, corticosteroid will be administered according to the gestational age and according to the maternal severity of the illness. But don't jeopardizing the patient life to administer corticosteroid. Development of diagram done by UpToDate. You can download it from there. And you can develop your own diagram. Anyway, all the information which we mentioned in the last 3 steps, the 3 slides, the condition precluding expectant management, maternal and fetal condition, as well as the timing of the delivery is including in one diagram. And this pathway and diagram, it is important to retrieve the informations. So try to study in this Intrapartum Management for patients with severe preeclampsia. Treatment of hypertension, seizure prophylaxis, anesthesia consideration, and antenatal corticosteroid. We will cover each part of this separately.
So do we have to follow our patients who diagnosed as mild preeclampsia as inpatients or outpatients? So different things will play important role in this decision. First of all, the patient education, the near setting of the hospital, the availability of the transportations, and how much it is easy for you to follow up these patients. They are committed to come twice weekly to the hospital or not. Patient education play a very important role. So you have to instruct patients about the sign and symptom of the development of the severe preeclampsia. Instruct her about if she developed headache, blurred vision, epigastric pain, severe epigastric pain or nausea. She have to come immediately report it to the hospital. Other things you have to follow up, laboratory investigation you have to follow up, and the fetal well-being you have to follow up. When we are talking about the laboratory investigation and for following up of the patients with mild preeclampsia, we are talking about repeating this investigation at least once weekly or twice weekly according to the patient condition. Which investigation we would like to do? We would like to do CBC, platelets count. We would like to do serum creatinine and serum ALT and AST. So we will do liver function test, kidney function test, follow up the platelets and the CBC. So you will guarantee that this patient is not deteriorating in one or in another way. Do we have to do 24-hour collection protein? Usually we are doing 24-hour collection protein in the first admission or in the diagnosis, but it has been shown that by several studies that neither the rate of increase nor the amount of proteinuria affecting the maternal or perinatal outcome in the setting of preeclampsia. So you don't have to repeat it once, is more than enough. How we are going to assess the fetal well-being? The first easy, cheap method is kick chart. Ask the mother to count the fetal movements. The other thing, you have to do non-stress test twice weekly with the amniotic fluid volume. And this is what we are calling modified biophysical profile. Or otherwise, you can do the biophysical profile for the patients. Assessment of the fetal growth restriction considered to be one of the first signs of the severe preeclampsia development. Ultrasound to rule out intrauterine growth restriction and oligohydramnios at the time of the diagnosis of preeclampsia, and then repeated it serially. Don't forget that Doppler avalocytometry is useful for assessment for fetal status if the fetal growth restriction is present. So now we are going to talk about the management of the patients with preeclampsia with a severe feature. We have been exposed in the previous lecture about the definition and the diagnosis, and now we are going to talk about the management. Do we have to administer antenatal corticosteroid? Remember that antenatal corticosteroid to promote fetal lung maturity should be administered to the woman less than 34 weeks of gestation.
So we know that seizure is considered to be one of the major causes of maternal mortality and morbidity in cases of preeclampsia or gestational hypertensive disease with a severe feature. The question which we have to ask ourselves is what medication we will use. Several medications have been used and studied: magnesium sulfate, phenytoin, diazepam, nimodipine, to prevent seizures. Evidence-based consensus agreement that magnesium sulfate is the main drug should be used to prevent seizure in women with severe preeclampsia, and the treatment and prophylactic for the recurrence of the attack in eclampsia. So do we have to use magnesium sulfate in mild or in severe preeclampsia? Magnesium sulfate have been effective in the prevention of seizure in severe preeclampsia. But the role of magnesium sulfate use in mild preeclampsia is controversial. Remember, when we are talking about the eclampsia, we know that 20 to 30% of the eclampsia occur without the severe feature, which is make us predict that this patient, she might go for eclampsia. So eclampsia occur 20 to 30% with mild preeclampsia. In my opinion, any patients with preeclampsia, whether it's mild or severe, should be covered with magnesium sulfate. We will discuss this later when we are talking about eclampsia. We mentioned that magnesium sulfate should be used to prevent and treatment of seizure in gestational hypertensive disease with severe feature. Remember that magnesium sulfate is more effective than other antiepileptic medication. But other antiepileptic medication are justified to be used when there is no magnesium sulfate or if the magnesium sulfate is contraindicated. Magnesium sulfate is contraindicated in certain situations. Can you guess? Myasthenia gravis, hypocalcemia, moderate to severe renal failure, cardiac ischemia, heart block, myocarditis. Remember that concurrent use of magnesium sulfate with calcium channel blocker may result in the hypotension. How to give magnesium sulfate? The loading dose, the maintenance dose, what is the therapeutic level, how we can monitor it. Think, pause for 1 minute, then continue. The dose of magnesium sulfate, 4 to 6 grams intravenously over 15 to 20 minutes. Do we have to give 4 grams or to give 6 grams? Remember that loading dose of 6 grams intravenously over 15 to 20 minutes, followed by 2 grams per hour as a continuous infusion, it is the recommended. Why not 4 grams as loading dose? Because subtherapeutic magnesium level less than 4 mg per deciliter are seen more often with 4 gram loading dose. Keep in mind when you are giving magnesium sulfate the kidney function test and if the patient is having renal insufficiency. So if serum creatinine is more than 1 mg per deciliter, give the standard loading dose since there is volume of distribution is not altered, followed by 1 gram per hour as a continuous maintenance dose. But if the serum creatinine is more than 2.5 mg per deciliter, give the standard loading dose but no maintenance dose, and do close monitoring of the serum magnesium level every 6 hours. Remember that magnesium level are reached more slowly during the antepartum period than the postpartum period. So we are going with 2 grams per hour antepartum. If you want to reduce it to 1 gram per hour postpartum, it will be also another alternative way. Magnesium therapeutic level 4.8 to 8.4 mg per deciliter which is equal to 2 to 3.5 millimole per liter. The maintenance phase is giving only if the patellar reflex is present, the respiration exceeds 12 per minute, and the urine output exceeds 100 ml every 4 hours. Following serum magnesium level is not required if the woman's clinical status is closely monitored for the evidence of potential magnesium toxicity. The risk of magnesium sulfate, as we said, that any medication, it's have effect on the mother and have effect on the fetus. So we should think in 2R, maternal effect as well as fetal effect. The maternal effect, we remember that 1/4 of the women reported adverse effect like hot flushes and feeling that they have tachycardia after the administration of the loading dose of magnesium sulfate. Postpartum hemorrhage have been reported in one trial, and they correlated this due to the uterine atony. Magnesium therapy also resulted in transient reduction in total and ionizing serum calcium concentration, which might lead to the parathyroid hormone suppression, and rarely symptomatic hypocalcemia like myoclonus, delirium, and ECG abnormalities. The rate of cesarean delivery was increased by 5%, and most probably due to the anxiety of the physician once they start magnesium sulfate, labeling the patients as severe preeclampsia. They are more prone to deliver the patients faster than waiting for the progression in the normal vaginal delivery. Magnesium effect on the fetus. Magnesium freely cross the placenta. Maternal therapy causes a slightly decrease in the baseline fetal heart rate as well as fetal heart rate variability. But don't worry about this. If you are not sure whether this reduced variability is due to the magnesium sulfate or is due to the fetal distress itself, go and stimulate the fetus. Even with a therapeutic dose, if you do fetal stimulation, the variability will get back to normal. So if you start magnesium sulfate, when you are going to stop it? Maintenance dose should continue for 24 hours after delivery, sometimes 48 hours according to the situation of the patients. If IV line not accessible, it should be administered by intramuscular injection, 10 gram initially as loading dose, 5 gram in each buttock, followed by 5 gram every 4 hours. How you will manage the patients if convulsion recur? If convulsion recur, further 2 to 4 gram of magnesium sulfate could be administered IV over 5 minutes. Point to be remembered when you are managing patient with eclampsia or severe preeclampsia, that magnesium sulfate administered intramuscularly or intravenously is superior to the phenytoin, diazepam, and lytic cocktail. The other point you have to remember that IV clonazepam, diazepam should be used cautiously only if absolute necessarily because they inhibit laryngeal reflex. What is the consequences? This is increase the risk of aspiration and also may depress the central respiratory center, leading to apnea. As we mentioned previously, whenever you want to administer any medication, you have to know the dose of the medication, the side effect of the medication interaction with another medication, and the toxicity of the medication if it's present. Magnesium sulfate, not an easy drug. Another way, it's have toxicity. So you have to know what is the sign of toxicity before you administer the loading dose. Never reported toxicity with the loading dose, but you have to be very cautious with the patients with renal diseases. So let us learn what is the sign of magnesium toxicity. We will talk now about magnesium sulfate toxicity. So how we are going to play it now, I will give you the statement and you will guess the answer, then you will get the appropriate answer. Deep tendon reflex are lost at serum magnesium level of 9 mg per deciliter, which is equivalent to 7 milliequivalent per liter. Respiratory depression occur at a level of, guess, 12 milligram per deciliter, which equal to 10 milliequivalent per liter. Cardiac arrest occur at a level of 30 milligram per deciliter, which is equal to 25 milliequivalent per liter. Remember that urine output should be part of the clinical monitoring. And if renal function is impaired, serum magnesium level will increase quickly. The infusion should be stopped and serum magnesium level should be determined at 2-hour interval if the serum level exceed what? Guess. 9.6 milligram per deciliter, which is equivalent to 8 milliequivalent to per liter. At this stage, you are going to give a treatment, which is calcium gluconate. What is the dose? 10% solution in 10 ml IV over 3 minutes.
So how we are going to deliver patients who have been diagnosed as severe preeclampsia? A lot of people rushing for cesarean section. You have to know that as obstetrician, our aim to deliver the patient safely and the fetus safely. So vaginal delivery will be accomplished in the majority of the patients under certain condition. Remember that the cesarean section delivery is associated with the reduced gestational age. So induction of labor with gestational age more than 34 weeks associated with a good successful rate. When a patient who is less than 28 weeks of gestation, they are having higher rate of cesarean section up to 97%. In the patients who is between 28 and 32 weeks of gestation, their cesarean section rate will be up to 65%. So treatment of patients with hypertension. Are we going to treat all the patients with hypertension? Is there any other modality to reduce the blood pressure in certain patients? Taking one by one, when we are talking about the antihypertensive medication, we know that to control mild elevated blood pressure in a setting of preeclampsia doesn't alter the course of the disease or diminish the perinatal mortality and morbidity. When we are talking about the sodium restriction, and diuretics have no role on the routine therapy. Restricted physical activity can't lower blood pressure, although its efficacy for improving perinatal outcome has not been proven. So now you decided to deliver these patients, and the patient is in the process of labor, whether in the induction or in the process of active labor itself. You have to keep your eye on this patient, and intrapartum monitoring is mandatory both for the mother and the fetus to detect early deterioration in the maternal condition or fetal condition. And this can be done due to close monitoring of the fetus monitoring as well as the maternal to identify any worsening in the hypertension or deterioration in the maternal condition, whether hepatic function or renal function or coagulopathy, as well as the cardiac function. Remember that the uteroplacental insufficiency or abruptio placenta is common with the patients with severe preeclampsia and can be manifested as non-reassuring fetal heart rate tracing or vaginal bleeding. Do we have to use invasive hemodynamic monitoring for all our patients? Patients with severe preeclampsia can be monitored simply with the simple measure without going for invasive hemodynamic monitoring, but there is certain situation where you have to use the invasive monitoring. Those patients who have severe cardiac disease, severe renal disease, they have severe oliguria, refractory hypertension not responding to medications, or they having pulmonary edema, those patients you have to do invasive hemodynamic monitoring to guarantee the best outcome for those patients. So antihypertensive therapy is important in treatment of the patients with severe preeclampsia to prevent the complication. And remember that there is certain indication for antihypertensive medication, and this is aiming to preventing the stroke, cerebral injury, and infarction. When we administer antihypertensive medications and when severe preeclampsia or when this patient who have severe high blood pressure with systolic blood pressure more than 160 and the diastolic blood pressure more than 110 millimeter.
So we mentioned that our goal is not to normalize the blood pressure. Our goal to keep the blood pressure 140 to 150 millimeter mercury systolic over 90 to 100 millimeter diastolic. But there is specific situation when there is end organ damage like renal disease, heart problem. It is desirable to keep the blood pressure below 140 over 90 millimeter mercury as low as to 120 over 80 millimeter mercury. So now we achieve the blood pressure which we want to achieve. What will be our plan in following up the patient who is coming with a severe preeclampsia? After you achieve the required blood pressure, repeat the blood pressure measurement every 10 minutes for 1 hour, then every 15 minutes for another 1 hour, then every 30 minutes for 1 hour, and then every hour for 4 hours. So 10 minutes, hour for 1 hour, 15 minutes for another 1 hour, then 30 minutes for the third hour, then every hour for 4 hours. The choice of the drug and the dose of the drug is very important. In each department, there is a written protocol. We have a written protocol in our department, so please follow up the step of written protocol. Sometimes some drug is available, the other drug is not available, so you have to choose between drug. And this choice should come within your mind what will be the appropriate medication you want to give. In acute management of severe hypertension, including one of the three main medication is used: parenteral hydralazine, parenteral labetalol or oral labetalol, immediate releasing oral nimodipine. We have to keep in our mind that the parenteral hydralazine increases the risk of maternal hypotension with systolic blood pressure below 90 millimeter mercury or less. What about labetalol? Parenteral labetalol may cause neonatal bradycardia and should be avoided in women with asthma, heart disease, congestive heart failure. Nimodipine has been associated with increase in the maternal heart rate and less risk of overshoot hypotension. So the treatment with any of these drug or this medication didn't require cardiac monitoring or specific monitoring. So no need for ICU admission for patients unless the policy of the hospital require obstetric ICU monitoring for all the patients of preeclampsia. But actually this facility is not available in most of our hospitals. Now we will cover the drug one by one and we will talk about them. First of all, labetalol. Labetalol is more or less safe in pregnancy. The loading dose of labetalol is 20 mg IV followed by 10 mg interval by dose of 20 to 80 mg up to maximum total accumulative dose of 300 mg. The fall in blood pressure begins within 5 to 10 minutes and last for 3 to 6 hours. If we have oral labetalol, also it is an alternative to the IV or parenteral labetalol. The dose of oral labetalol is 200 mg orally dose, can be administered, which can be repeated within 30 minutes. Initial regimen of labetalol at 200 mg orally every 12 hours and increase the dose up to 800 mg orally every 8 to 12 hours as needed. The maximum total is 2,400 milligram per deciliter. Hydralazine is a drug which can be given intravenously, oral, or intramuscularly. Remember that in acute cases with a high blood pressure, the appropriate route of administration of hydralazine is intravenous. But also remember that this IV administration can lead to hypotension, maternal hypotension. The dose is 5 mg intravenously over 1 to 2 minutes, a slow administration of loading dose. If the blood pressure is not reached within 20 minutes, so you give it, check the blood pressure within 15 to 20 minutes. If the acquired blood pressure didn't achieve, give another 5 to 10 mg bolus, depending on the initial response. Remember that the maximum bolus dose is 20 mg. Nimodipine is the third drug which we are using in severe high blood pressure. If the blood pressure more than 160 over 110 in the cases of severe preeclampsia. So you give immediate releasing nimodipine 10 mg orally and observing the blood pressure every 15 to 20 minutes. If you achieve the required blood pressure fair and well. If you didn't achieve required blood pressure, you can repeat another 20 mg orally nimodipine and observe the blood pressure. If the patient developed hypotension, you have to inform the physician if you are the nurses which you are following up the patients. And blood pressure should be repeated every 20 minutes. You are allowed to repeat another 2 doses of nimodipine, so the total of 4, 10, 20, 20, 20. If no response, you add another medication. Calcium channel blocker, we said nimodipine. Nimodipine have many routes to be administered, sublingual, oral, but sustained releasing nimodipine 30 mg immediately released. Nimodipine sublingually, it is carrying a high risk with excessive reduction in blood pressure and leading to the serious cardiovascular morbidity. So it is abundant using sublingually unless it is in specific situation with the cardiologist supervision. And nicardipine are option, and it can be given only intravenously when there is no available nimodipine or when the failure of nimodipine and other labetalol hydralazine medication, and it should be administered in the ICU under supervision of the internists or intensivists. So when adequate blood pressure control cannot be achieved with labetalol hydralazine or nimodipine, you can give diazoxide 15 mg every 3 minutes to a maximum of 300 mg. Other medication can be used in refractory severe hypertension like nitrous oxide. But remember, it is contraindicated in the last stage of pregnancy due to the possibility of fetal cyanosed poisoning if it's used for more than 4 hours. So nitrous oxide 0.5 to 10 microgram per kg per minute can be considered an agent of last resort for urgent control of refractory severe hypertension. So it is risk-benefit ratio. In the cases of severe hypertension, it's not controlling by multiple medication. You can use it, but it shouldn't exceed 4 hours and it should be under close supervision. Angiotensin converting enzyme inhibitor and angiotensin II receptor blocker is contraindicated at all stages of pregnancy as they are teratogenic and you cannot use it. So long-term oral therapy, we know methyl-dopa, hydralazine, labetalol, all they are available in oral form. Methyl-dopa is 250 mg twice daily orally, and the maximum dose is 3 grams per day. If you didn't achieve your required blood pressure, you can raise the dose for 500 mg Q8 hourly. Mild antihypertensive agents is safe in the fetus. but remember it's require most probably it require 48 hours to act. Labetalol, it can be given, there is 100 milligram 2 or 3 times daily orally. The maximum dose you can reach is 1200 milligram per deciliter. Have both alpha and beta adrenergic blocking activity. Propranolol is somewhat controversial due to the individual report of the premature labor and neonatal apnea, fetal growth restriction, bradycardia, and hypoglycemia, so preferably to avoid propranolol. Nifedipine, 30 to 90 milligram once daily as sustained releasing labetalol, increased to at 7 to 14 day interval. The maximum dose is 120 milligram per day have been used without major problem. So you cannot raise it so frequently. In my opinion, I will start with labetalol. It's the safest, fastest acting, and you can manipulate the dose and you can reflect the result immediately. Postpartum course, we know that preeclampsia, it's most probably hypertension, proteinuria will resolve in the postpartum period. Sometimes the patient, she's persisting severe high blood pressure, so you might discharge her on antihypertensive medication, and you can discontinue it whenever the blood pressure is continued. So if you discharge your patient on antihypertensive medication, let her visit you weekly so you can reduce the dose till you stop the medication. If high blood pressure persists more than 12 weeks, then refer the patients for the internists. Then this patient, she's more probably she's having chronic hypertension rather than severe PET. Antihypertensive agents for breastfeeding mother. Before we initiate antihypertensive agents, we have to be sure it is safe for the baby. And this antihypertensive agent should have minimal excretion in the breast milk. Labetalol and propranolol are preferable for initiation of antihypertensive therapy because these drugs are not concentrated in breast milk. Alternative, nifedipine and verbamine. There is certain drug is contraindicated in breastfeeding mother: ACE inhibitor and angiotensin receptors antagonists, beta adrenergic blocker and calcium channel blocker enter breast milk. Most appear to be safe during lactation. Diuretics is not preferable because it's reduced milk volume, but this doesn't appear to occur at a dose of 50 milligram or less daily. Antihypertensive patients, if the mother is breastfeeding, you can use breastfeeding, we talk about them. In the non-breastfeeding patients, like angiotensin converting enzyme inhibitor, beta blocker, calcium channel blocker, and diuretic can be used. Avoid aldomate because of the risk of depression, postpartum depression. Patients with preeclampsia recurrency rate, it is have been studied in several meta-analyses, one of them in 2015, and they found out that the women with PET, they have 7% to develop preeclampsia in subsequent pregnancy. Why this important information? Because when you are counseling your patients with preeclampsia, you will tell her that her risk is around 7% if she is preeclampsia, and this risk could be high up to 15% with the patients who's having gestational diabetes. This high risk is important to be explained, as well as you advise the patient with the next pregnancy to give her low dose aspirin, because it has been proven that this category of the patients who is high risk patients, if you give them aspirin, this is going to reduce the risk of recurrency of preeclampsia. Long-term sequelae of gestational hypertensive disease in a pregnancy, including chronic hypertension, unfavorable lipid and glycemic control in the future, and cardiac disease. Before we finish our lecture today, I would like to just tell you that we separate the chronic hypertension and gestational hypertension because we want to discuss a specific point about these important. The next lecture won't be that long about gestational hypertension and the chronic hypertension because more or less the medication is almost the same. But this specific point we will cover. Follow-up of the patients will be a little bit different from patients of preeclampsia. The fourth lecture will be about eclampsia and HELP syndrome. Thank you.